Hi, Alex.
Morning, Fernanda.
How are you doing?
Not too bad, you?
Doing well, thank you.
Good to hear.
Everybody.
Good morning, everyone. We're just waiting for more participants to flow in, as well as our speakers to join us. So we'll be starting hopefully pretty soon.
Hi, Alex. Just to say, I've just had an email from Stefan saying he's running a few minutes late.
Okay.
He'll join us as soon as he can. He's our discussant today, but I know he's seen the slides in advance, so he is all prepared.
Perfect. All right, so we'll begin hopefully in a few minutes. We'll wait till about 9:05, see where we're at. We still have a few people trickling in, and hopefully Stefan will be able to join us.
Great.
All right, I believe we have everybody here. So let's take a look. So thank you everyone for joining us this morning or afternoon, depending on where you are. My name is Alex Saunders. I'll be your webinar manager for today. So today's webinar, we're very thankful to have some wonderful guests with us handling social variation and health opportunity cost in England. The webinar is set for 60 minutes as of right now, so we'll play with that number and see where it goes. And before we begin the webinar, I just wanted to run through a couple administrative items. If you do run into any technical issues, if you're having difficulties accessing the material, if you get kicked off, or if you have any issues within the platform itself, please use the chat function and we'll be able to help you out. Or if you have trouble getting back into the webinar, please feel free to email us, and with the email that you receive the webinar invitation, we'll be able to try and help you out further. If you have any questions during the webinar, please use the chat box as well, and that's something we'll address at the end of the webinar. So without further ado, I'd like to pass it over to Naomi Gibbs, and she'll take it from there.
Thank you. Great. So I just wanted to extend a welcome to everybody. This webinar today has been organised by the Equity Informative Economic Evaluation Group. This is a special interest group within IHEA. I'm one of the conveners, and Stefan Virgo, who's our discussant today, is one of our other conveners. If you want to know more about the group, we've got a page on the IHEA website. So essentially, though, it's a group that's interested really in how economic evaluation can be more equity informative in order to aid decision making around health. So I'm not going to say much more than that. Just going to hand over to Dr. James Loveco, who we have today, who's going to talk us through some of his most recent work. Thanks, James.
Thanks very much, Naomi. Thanks for the invitation. Thanks for everyone for joining. So I'm going to be talking today. I hope you can all hear me, and I hope you'll see my screen. So I'm going to be talking today about the role of health opportunity costs in equity informative economic evaluation, and with particular focus on a study that we did that was published last year as that estimated the distribution of health opportunity costs in England. So a couple of acknowledgements to begin with. So firstly, there's two pieces of work that this was based on, this presentation was based on. The first is this paper that I just mentioned. So my co-authors, Richard, Carl and Susan, and Anita and Paul as well for their comments. And the second is a chapter that I wrote for the distributional cost effectiveness analysis handbook that was also published late last year. And with particular thanks to Ulla, Tony, Jessica and Solomon for all of the comments they gave me on that chapter as well. So to get on to today's topic, this is a definition of opportunity costs. It's quite a common definition. So the value of a resource in its most highly valued alternative use. And what that basically means, I'm sure many of you are familiar with this concept, is just that for every time we make a decision to allocate resources to somewhere, that's a lost opportunity to spend them somewhere else. And so the value of that resource is the value that we could have got from spending it in that alternative use. So most highly valued alternative use is probably a bit of a stretch for a lot of healthcare decisions, because it assumes some kind of allocative efficiency. By that, I mean that if we spend a whole bunch of money on a new resource, on a new intervention or health program, it's not necessarily you're not necessarily going to be foregoing the least valuable other thing that you've done. So it's more of a pragmatic thing about what the actual alternative use is going to be. So what kind of health opportunity costs are relevant for economic evaluation? So I think that depends on how we're going to value that health intervention. So the most common one is, of course, health itself. But there are also other criteria that we evaluate health interventions on, like financial protection, like avoiding catastrophic health expenditures that could cause someone to go into poverty. And it could also assist people in maintaining productive contribution to society. So I'm going to focus entirely in this talk on just that health component, because it's pretty much health is obviously the thing that we focus on the most in cost effectiveness analysis. But of course, we shouldn't be forgetting all of those other types of aspects of value. So just to illustrate what I mean by health opportunity costs. So you can see here that if we have this set of health resources of which we want to spend $20 million on this new program, then we can use decision modeling or whatever kind of economic evaluation approach that we've adopted to estimate what kind of health benefits that we might get from that new program. And here I'm going to be talking exclusively in this talk about QALYs, but obviously the same applies to other metrics of health. So when we're thinking about opportunity costs, then we're thinking about those foregone services. So as a result of spending that 20 million on that new program, we've foregone $20 million worth of other services that we'd previously been funding, and those services were also generating health benefits, and they're not anymore. And so therefore we have those health opportunity costs, which we can quantify also in terms of QALYs. And the difference between the health benefits and the health opportunity costs are, of course, the net health benefits. I'm sure many of you are familiar with this metric. So what about when we want to talk about distributions of health opportunity costs? Well, this just makes things a lot more complicated, as you might imagine. So our new program is going to generate health benefits for all of these different groups. We've got groups A, B, and C here. I'm going to be talking a lot in this presentation about income groups, but we could be applied to any type of equity relevant characteristic, for example, ethnicity or or geography. So they've got those health benefits, they're distributed to these groups. And then the foregone health services are also going to have a distribution across those social groups. And so we have a distribution of health opportunity costs. And I think one important thing to note here is that it's not just the costs that are generated within those groups, it's the total cost, which then creates a resource impact that affects the health services, and then the health services are what generates the distribution of health opportunity costs. And so then we can calculate net health benefits for each of those groups, and that's going to be our kind of starting point for equity informative economic evaluations. So I just want to spend a bit of time about just trying to convince you that the distribution of health opportunity costs can be quite influential. So created this very simple numerical example where we have these three groups with different healthy life expectancy before the intervention is implemented, so 60, 65 and 70 healthy life years. And then we have this intervention which favours group A more than the others, so 8 QALYs are generated in group A versus 6 in group C. And then we have this total amount of health opportunity costs, which amounts to 12 QALYs. So thinking back to that last diagram, if we distribute the opportunity costs equally between those three groups, then we have 4 falling on each group. And so the net effect, which is that third row there in the second table, shows that the net health benefits are still favoured towards group A, which we can maybe assume is our low income group or whatever, because they have the lowest health. And so when we calculate the post-intervention health, we reduced health inequality from 10 years to 8 years. Alternatively, say if our health opportunity costs also fall on the least healthy group, so we've got 50% of the opportunity costs are falling on group A now, that the net effects are reversed, that now group C have the largest net health benefits, and when we look at post-intervention health, we've actually increased health inequality. So holding everything else constant, but changing this distribution of health opportunity costs can reverse, or potentially reverse, the health inequality impacts of an intervention. So how do we estimate health opportunity costs in the first place? So I'm going to talk briefly about this very complex and deep topic that forms the basis of any analysis of the distribution of health opportunity costs. And the way we can think about it is through this health production function. So we have a set of resources and the outcomes that are generated by those resources on the y-axis. And it's this concave function that with diminishing marginal returns. And so when to estimate health opportunity costs, we might want to think about how, if we change from our current level of expenditure, if we change that level of expenditure, what's the health impact going to be? So as illustrated by these differences here. And then the ratio of the change in expenditure to the change in health is this marginal cost per QALY. So how much, when we've changed our expenditure, how much health we're expecting to gain or lose. And so the way that this connects to health opportunity costs, of course, is that if we go back to that diagram I showed you earlier, where we've got this new intervention that costs $20 million, that's like saying, okay, so we've now reduced the health expenditure pool for everything else by $20 million. And so we can think of that change in E there as being $20 million, for instance. So this is obviously a case where if we've got a fixed set of health resources, I mean, there are opportunity costs a lot more complicated when we're thinking about insurance systems, where the insurers might raise premiums or reduce premiums. And then you get individual response in terms of people reducing their coverage or disenrolling from health insurance. We're kind of keeping it in the simple example here, but there have been explorations of more complicated situations of opportunity costs. But I'm going to stick with this kind of simple example at the moment. The general empirical approach for connecting these two together, so for estimating that point on the production function, so we want to go from the change in health expenditure to change in our health outcomes in terms of QALYs. So the first thing to do is to estimate some kind of econometric model. This is a very, very difficult thing to do. And this area of research, so cost effectiveness threshold, research goes back maybe around 7 or 8 years. The literature around estimating the link between healthcare expenditure and health outcomes goes back a lot further. It's just been limited mostly to connecting health expenditure to mortality. So there are lots of different difficult issues around connecting these two things together. And so studies have tended to use things like instrumental variables to estimate this relationship to get a mortality outcome elasticity. And then to go from mortality, and say mortality there, I've got YLL, that's years of life lost. So when we change our health expenditure, how many years of life have we gained or lost? And so getting from mortality, so just those life years, to some kind of generic measure of health that accounts for health-related quality of life, that's an altogether more difficult and complex process. And the studies that have done this have all gone about it in various different ways, but they've usually involved things like having estimates on health-related quality of life, estimates by age, sex, and disease, and maybe looking at things like the overall disease burden in particular disease areas, and then making some assumptions and modelling around that to go from mortality to a generic health outcome measure. So our study that was investigated distribution of health opportunity costs in England is based around this study here. It's quite a famous study from led by Carl Claxton and others here at the Centre for Health Economics at York. So this was one of the first to estimate cost effectiveness threshold. Many have come since, and their approach to link together healthcare expenditures and total health effects was to essentially have a whole bunch of different models that estimated the change in overall healthcare expenditure, how that affected individual disease areas. So they had healthcare expenditure by disease area, health outcomes by disease area. And I should also mention that there was a cross-sectional analysis as well. So it was looking at the variation in expenditure and the variation in disease mortality across geographical units. So primary care trusts, they're called in England, which are responsible for allocating resources in a particular area. So you estimate the health effects in each of these individual disease areas, and then you sum across them to get that total health effect from that initial change in healthcare expenditure. And the disease areas are grouped under these things called program budgeting categories, which relate broadly to ICD chapters. So that's important later on because we map from ICD information to these program budgeting categories. So the fact that this study estimated disease-specific health effects, that was the thing that allowed us to investigate the distribution of health opportunity costs, because by disaggregating the overall health effect into these separate disease areas, we were able to look at the social distribution of these disease areas, of these disease populations, and using the social distribution of healthcare utilization by all of these characteristics, we were allocated the health effects for the overall disease area to these equity relevant subgroups. And so I've got it here for respiratory disease, just 3 subgroups. There was 80 subgroups in total because we had 8 age groups, 5 socioeconomic groups, and for males and females. And so you can do that for each of the disease areas, and then again, sum across all of the disease areas, and then that gives you the social distribution of the health effects of the opportunity costs. So I think I've highlighted in that last slide that we use 3 social variables. So in order to allocate the health effects by age and sex, Claxton and others, as a sort of supplementary piece of work to their threshold work, had already done this by age and sex, using prevalence data for each disease area from the global burden of disease. So we had that distribution by age and sex already. So to incorporate socioeconomic status, we used data from hospital episode statistics, which is a administrative data from England, which covers all public hospital activity in England. So the data set might look a bit outdated. That's because this was the most recent available data set when we began this research. So it was quite a while ago. And the sample that we had included nearly around 20 million healthcare episodes in total that covered 9 million patients. To measure socioeconomic status, we use this thing called the Index of Multiple Deprivation, which is commonly used in England and the UK. So the important thing about this is that it chops up the country into about 35,000 different small areas and then estimates the deprivation level of that small area according to some data on things like education, income, and I think 5 or 6 different other dimensions of deprivation. And so we used a 5-level variable for socioeconomic status, in which all of the groups are evenly sized. And it has information for each episode on 3-digit ICD codes, which we were then able to map to the program budgeting categories. So quick overview out of this, and it also illustrates what exactly we did. So say you have this 1% change in NHS expenditure. So that creates around 60,000 QALYs, change of 60,000 QALYs. Nearly 18,000 of those go to respiratory disease, which is the largest disease area in terms of health effects. And so 1,000 go to 30 to 44-year-old females. Set of the distribution, as I mentioned, comes from this global burden of disease prevalence data, and disaggregated further to socioeconomic groups. So for females aged between 30 to 44 who are in the most deprived group, they had 291 of those 1,097 QALYs, and that's based on that hospital episode statistics data. So here's what the inequalities across IMD groups are for each of those program budgeting categories. So this is just the proportion of healthcare episodes in HARES I've ordered them in terms of the size of the health effect. So how much of that overall health effect is attributed to each of these disease areas. And so those top 4, so respiratory disease is around 30%, and then the next 3 are just over 10% each. So those top 4 account for, I think, nearly 70% of the overall health effect. And basically what we can see here is that if we expected them to be evenly distributed, they would be about 20% each, so 0.2 per IMD group, but we're seeing a socioeconomic gradient in virtually all disease areas except for cancers and tumours, which was the one that was pretty much evenly distributed. And so this was the information that we were using to then disaggregate those health effects in each of those disease areas. So what is the IMD distribution? So it's the socioeconomic distribution of those health effects. We have a clear socioeconomic gradient. So in the most deprived group, IMD1, it's about a quarter of the health effects, and that proportion decreases until we get to that least deprived group, which only has about 14%. And remember, all of these groups account for about 20% of the population. In terms of the gender breakdown, it's females that have a larger proportion, but it's not a huge difference. We also saw clear differences in the socioeconomic distributions by age. So a much larger gradient was found for younger age groups. And by the time we get to analysing people over 80, we're almost at a uniform distribution across the socioeconomic groups, possibly attributed to some kind of survivor effect. So in terms of the sensitivity analysis that we looked at for the robustness of these results, well, we couldn't do that much. We did try looking at previous years of HARES in case there was any kind of temporal effect. As you can see here, the differences from the previous 2 years of HARES were minimal. The other thing we did was, instead of counting the proportion of episodes by IMD group, we counted the proportion of patients, so just the individuals who were in the HES data set. And you can see here that it creates a slightly flatter distribution. So, so when we use patients, there's a slightly smaller proportion for IMD 1 to 3 and a slightly higher proportion for IMD 4 to 5. But when we think about that distribution I showed you before, the IMD1 had about 0.26. So a difference of 0.0025 is around 1%. So these differences are still quite small, even when we change from episodes to patients. I think the other thing that we wanted to investigate was the fact that we're using hospital data, we're using secondary care data here to allocate all disease areas, when in fact it's probably the case that most people, for a number of disease areas, you can think of things like asthma or mental health, or particular conditions that are treated in either specialist facilities or in primary care. So we wanted to use some kind of data set that related to primary care that we could use to compare our distributions from HES with, and see how reliable they were. And to do this, we used a freely available data set called the Quality and Outcomes Framework, which is a incentive scheme for primary care doctors, but as a result of trying to calculate whether those incentives should be paid or not, they have to calculate disease prevalence. And so we were able to use these prevalence data by IMD to then compare those distributions with what we got out of HES. And so the kinds of conditions that they had recorded in this QOF data set involved obesity, asthma, depression, dementia, a total of 19 conditions. And then when we actually mapped those to the health effects, it accounted for around just under 40% of that total health effect. So it's a good proportion. And I should also say that we didn't map these to PBCs, we actually mapped these to the individual ICD codes that related to each of these conditions. So it's a slightly more complex sensitivity analysis. And when we compare our base case analysis with using the QOF data, we can see that there's slightly different distribution. So seeing a slightly steeper gradient in terms of the least well off in society, the most deprived in IMD1, but it's not a huge difference again. And so, by the way, so in case you're wondering, so these rows here, they sum to 0.37 as it's relates to 37% of the total health effects. So the last set of results that I wanted to show you were these region analysis. So each of the local authorities in England, they're made up of lots of these different small areas, and some more deprived than others. And so we can use the fact that we know that the distribution by IMD to calculate what regions are going to be mostly affected, or more affected than we would expect based on their population size. And so we're able to create this map that the darker sections indicate that the health opportunity costs are disproportionately large compared to the population. And so we can see in the urban areas where you see more concentrated pockets of deprivation, so Greater Manchester, Birmingham and London, they're easily the darkest centres on the map, and that just accords with their levels of deprivation. So limitations and assumptions that went into this work, well, there are many, including all of those in the initial Claxton et al. Threshold study. There's been very active conversation in literature around all of these assumptions, which I think is still ongoing. And so all of those assumptions still hold for the results of our study. The other thing is that we've got those marginal health effects by disease area. So that we know that those disease areas are being affected at the margin, but we're using average patterns of disease prevalence and healthcare utilization to distribute those health effects. So the marginal distribution of healthcare utilization might be different from the average effect, the average pattern. It's quite possible, but to estimate that marginal distribution is very large empirical challenge in and of itself. So it wasn't something that we were able to attempt in our study. You'll also notice no estimates of uncertainty, unfortunately. We did try and propagate some uncertainty using the distributions, but if you don't have the uncertainty coming down from the econometric models all the way through to the health effects by social group, then you're going to vastly underestimate your uncertainty. And so it was, we decided that it wasn't that prudent to publish those. And the other thing is using health benefits, using episodes to distribute the health effects. It's got this implicit assumption in there that for every episode of care, you get an equal health benefit between socioeconomic groups. So that is another tough empirical question that needs to be addressed. There's some work that suggests that maybe people in higher income groups are better at adhering to care or things like that, and so you may see a distribution across the health benefits per episode of care, but it wasn't something that we could incorporate into our analysis. And then lastly was this issue that that I pointed out towards the end there with the QOF data set, that we didn't have primary care or specialist mental health care, for instance. We didn't have utilization data on that. So we had prevalence data for some of those primary care conditions, but not utilization data. And so I think that represents another big limitation of this. Right, last slide. So future research. So I think that the main barrier to people conducting studies like this of their own is the fact that we don't have that many marginal productivity studies. There's a good reason for that. They're very data intensive and they require a lot of work. We were very lucky in this instance in that the English marginal productivity study estimated by this disease area that then we could so we used that, provided a handle by which we could then link it to social groups. It's less obvious how to do that if you don't have health effects by disease area. Alternatively, if you don't have the marginal productivity studies, then just in terms of using, having some kind of distribution of health opportunity costs, some kind of informed scenario that you could use in your economic evaluation, things like benefit incidence analysis, which is a kind of cost-weighted utilization distribution that was favored by the World Bank maybe 15 years ago, but you don't see many of them around anymore. But benefit incidence analysis definitely could be something that could be used as an informed scenario of how those health opportunity costs could be distributed. And lastly, a topic that I mentioned right at the beginning of the talk, which is just that the opportunity costs, they're not just in terms of health, they're in terms of all sorts of other outcomes. And it'd be, I think the literature on those is fairly scant right now. And so definitely look forward to seeing more work done in that area. So I think that is all I wanted to say. And I think I've just about managed to keep the time. So thank you very much.
Thanks, James. That's brilliant. Stefan, we're going to go straight over to you first of all for your thoughts on it, and then we're going to open to broader questions.
Yes, great. Thank you very much, James. It was very clear and stimulating presentation. I would have 3 comments. You can hear me okay, right? Yeah, sure. So, which are more like questions, actually. One is more empirical on the data, another more conceptual, and then another one more on the application for decision making. So the first thing was on the empirical side, you have this rectangle with health resources, and I was wondering if you could elaborate a little bit about what that means in the context of England, and also as you have some experience perhaps in where there's detailed budgeting exercises across other, say, European countries, how definition of healthcare expenditures might quite vary from settings to settings. And I know you mentioned primary care, for instance, but how there may be differences in categorization and how that might be an issue. in terms of applying or not. Maybe it's easy to adapt to apply those methods. So that's one set of things. The second is a more conceptual, and I'd like to hear your thoughts about the definition of health budget. And I'll give two directions here, but there may be others. One is that, as you know, and in fact, that's, I think, especially relevant in the context of equity, which you're addressing in this, understood in terms of distributions across SES. Health is part of, in a welfare state, it's a sector through which, it's in some ways integrated within social protection. And it's just a way that you redistribute things. So with other programs, education is an obvious one, but it's a different topic. But I wonder whether, so just on that front, that especially as you move toward distributions, how it's really, maybe there's, you might consider, maybe you're considering now, about expanding the definition of a health budget, maybe thinking more about the taxpayer money, more generally speaking. Maybe that's too broad. The second aspect is simply that, in fact, we're just in the middle of living this, is that health systems, or maybe the medical clinical systems, which is, you had like hospital episodes in that example. I know this is not the only examples you can done research on, but they're only a small component of driving the health outcomes. In other words, if you have safe roads, people have not risk factors, they don't breathe bad air, there's not a pandemic going around, they have healthy foods. So that is, and I'm not saying, maybe some thoughts about, also from that perspective of that second bucket of things, which is on the conceptual, where are the limit of the budget? And I know in England you have very clear definitions about this, but that might not be in other places. And I wonder, maybe there's a need or not to expound a little bit. And of course, that also deals with social determinants of health and so on. And then the third thing was about the application. That's a little bit more opening, a bit more loose sort of comment, is I wonder about, of course, technically speaking, that thing can be adapted, but I wonder, especially so in the light of the COVID pandemic, you have a definition of fixed budget over certain time periods. Now, obviously, you can look at multiple time periods, but that, in places where interest rates and borrowing are low, one can think about, investments. Now, you can perfectly include this in this framework. But I wonder, the two last points in terms of decision making is one, which is about, maybe it's related to a second point, is there, other broadening of health budget more in maybe investments, and thinking about, broadening the definition of a big budget, that fixed budget I can think of. And I guess more broadly speaking is, I wonder, more generally, in the light of the COVID-19 pandemic, whether your approach to economic evaluations, health opportunity costs, where maybe if the pandemic has made you, adapt, rethink, or you thought about new directions, and that maybe that has challenged, and I think it's more general question, the way that we conduct, it's not specifically this technical applications here, but the way we conduct economic evaluations. So that's it from my side, but thanks very much indeed.
Thanks a lot, Stefan. Yeah, some big questions in there. So yeah, I'll do my best to try and give my thoughts on some of the points you made, which I think they really get to how we deal with health opportunity costs in economic evaluation and the scope of economic evaluations more broadly, as well as their distribution. So just to go through some of your points. So when I mean healthcare resources, obviously in England, it's a lot more simple case in that we have a single payer. We do have a private system, but as a vast majority of healthcare expenditure is on that single payer. So when I draw that box, it's relating to total NHS expenditure, which does provide an opportunity to apply one study that then can estimate health opportunity costs for an entire country. It's a lot more complicated, as you mentioned, if you look across Europe, where you have competing social insurance schemes. I did try to touch on it in the presentation, just about how you can try and incorporate some of these more complicating factors, like the ability to switch coverage, individuals' ability to switch coverage, individuals' ability to disenroll from care if it's a private insurance scheme. So yeah, these kind of empirical approaches tend to work when you're focusing instance, or just public health expenditure that's somehow siloed off from other expenditure, because the health opportunity costs will then be only relevant to that expenditure. I'm not sure if that is a satisfying answer to your question, but yeah. In terms of the broadening across sectors, I think this is a perfectly, it's a great point, and one that I think we need to really think about as part of this special interest group, because healthcare is only one component of the determinants of health inequalities. And I think the reason that I've stuck to just the health budget in this type of analysis is because it's building on that economic evaluation framework in which we only analyse the health consequences, and we limit ourselves to those health consequences. And we're only concerned with the health budget as being distinct from other areas of expenditure. Now, there's plenty of research that's being done. I know my colleagues here at York have looked at how to look at cross-sectoral analysis, so in the criminal justice sector and other forms of expenditure that also have an effect on health and could also have an effect on health inequalities. And I think you're right to mention things like the social determinants of health, which could be far more influential in determining inequalities in lifetime health than, say, provision of particular healthcare interventions. The other point that I just wanted to make was one that you mentioned about relating to COVID. I think we've definitely seen, as you say, with the huge increases in government borrowing, that we're not in a kind of marginal situation, or we're not currently in a marginal situation because we can borrow such huge amounts and drastically change the levels of healthcare expenditure if we need to. And I think that's a very, very big question for health economics, and how health economics can be useful in situations like that, because this whole literature around economic evaluation has always been centered around marginal decisions and moving from one to the next. And so I think I'd be very keen to hear if anyone else in attendance has any thoughts on this as well, because it's not something that I could even begin to claim to have the solution to, but it's a very important point.
Great, thanks, James. I'm just going to open it out for other people to ask questions. We've got a bit of time for some more questions. Somebody did put one in the chat, actually, which is quite a technical one. Mark Dusheko, I don't know if you want to unmute yourself and just put your question to James. If you're
hi, James. Thank you. You actually answered the question in your summary slide. It's just the essentially you assume that the additional expenditure has the same marginal benefit across the different socioeconomic groups. But because I was kind of thinking, it's quite a nice empirical question, which you could probably address with your data to see does the marginal productivity, is it higher if if the additional expenditure on lower groups, you could think that maybe if there's more unmet need, the additional expenditure might have a bigger benefit in the more deprived areas than if in the wealthy areas, say for instance, the supply is already quite good, or access is better. That additional expenditure might not have as great an impact.
So yeah, I think it's another crucial point. I think, as I mentioned at the end, that that using those average distributions is definitely a big limitation from our application. I think what you kind of getting at maybe in the actual econometrics, including something like an interaction term or analysis of subgroups based on their IMD information. So kind of, yeah, because I think that would be the case. A way to get at this is if you had the health effects you could directly estimate the health effects by the socioeconomic.
I think Carl's original paper, he did it by primary care areas. Okay, there was 150, so you could, or maybe you could split them into, I don't know, the 30 most deprived areas, and I don't know if you have enough data to see whether, in the 30 most deprived areas, if there's an increase in expenditure, is the effect on mortality larger than if the expenditure increased in the the 30 least deprived areas. So,
yeah.
But again, I think you probably need a few more data points.
Yeah, so I think that might be possible since because primary care trust no longer exists. I should say for others listening that the data set that I mentioned, there was a cross-sectional analysis to estimate the relationship between expenditure and outcomes. That's based on a sample of around 150 primary care trusts is how it was allocated. I think since then, there have been a number of different reforms, and more recently the CCGs, the clinical commissioning groups. There are around 300. You can get a larger sample. And I think there's some at York potentially exploring that, but yeah, it's not something that's been done or attempted.
Okay, thanks, James. We've got another question from Paolo Candio. If you're there, if you want to put your question to James, and then I've got a question if I can jump in after that.
Sure. Thank you, James. Very, very nice presentation. Very stimulating. So I just wondered from a more computational standpoint. So you mentioned that, of course, because of data limitation, use the cross section to calculate what is the actual value in terms of qualities of a change in 1% of the health expenditure. So I wonder, technically speaking, so the health-related quality of life component of the quality, which I suppose was sourced from EQ5D or SF36 questionnaires, I suppose. Was that as well a cross-section, I suppose, sample from the patient, or was more an estimation of the lifetime, the average lifetime patient? And if so, in terms of the 1% change, it has been taken into account the fact that, of course, at the margin, so the 1% is not going to make a lot of difference. But of course, if you drastically reduce to 20%, of course, this is more like hypothetical, I suppose, than in practice. But then the efficiency will be higher. So basically, you will produce more qualities, just because, of course, the way technology typically works. So, yeah. Thank you.
Okay. So firstly, I wasn't a co-author on that initial paper with Carl, but I probably one of the few people who's read the entire 400-page report. So I can try and answer that question. So basically, it was the econometric analysis estimated so for a proportional change in the health budget, what's the proportional change in the years of life, total years of life lost in a particular disease area. And so you can estimate, so that gives you an elasticity of outcome to expenditure.
Yes.
And then you apply that elasticity to the disease burden, the whole disease burden.
Right. Okay.
So that includes all of the health-related quality of life effects. So that's not just the health-related quality of life of the people who've died, but also sort of pure benefits in terms of. So and you had there was another part to your question, but I've forgotten it now. I'm sorry.
No problem. The other section is, of course, that is just more, I think, a point of discussion rather than a question, because it's not easy to answer anyway. But of course, when we think about changes, always at the margin, right? So, especially when you talk about the opportunity cost. So if there are no structural changes so that the impact of the budget is massive, we can sort of safely assume that the value of the opportunity cost is sort of pretty much there. Of course, if you were to change 20% of the budget, then of course the value of the services displaced will be much higher, because of course the technology changes over time. So what's your thought on that, especially considering when you were, for example, to repeat the analysis, because I think this is an amazing piece of work. It's just incredibly challenging to do without expertise and a team of people. But I think because of the shift in local in the responsibility by local authorities, it would be amazing to sort of not teaching them, but at least show them what this means in practice, and where actually the changes in budget are more dramatic, especially because they are being slashed probably. So what are your thoughts on this?
Yeah, so I think this is definitely a question for economic evaluation more broadly, in the sense that in all economic evaluation, we kind of assume that there's this constant threshold, and we use this threshold value to compare our ICEs with, and that threshold value doesn't really change. We've used a 20 to 30,000 value in England for the last 20 years. And so, how conducting these types of analysis on a frequent basis to see how which section of that production function, which point of the production function we're at, is an important social task. In terms of how we deal with changes in expenditure, which I think kind of a little bit comes back to Stefan's point as well, where we're seeing large changes in healthcare expenditure, we're not going to see marginal changes. And there has been some work done. I know James Lomas has done a paper on a very theoretical kind of conceptual paper on how we would relate those non-marginal changes and what that means for healthcare. But yeah, this is it's a very, very keep saying this, I know, it's a very difficult empirical question.
No, agreed. Very, very difficult point, but it's important that researchers do this, because of course it's going to make a lot of difference in terms of resources available, and also keeping the focus on how important it is to preserve, maximize the value of the budget. So thank you, James.
Thanks, Paolo. I've got a question now, James, if I may. I think there aren't any others lined up just yet, and we've got time for one more. So we sort of promised a little bit that we might talk about this in relation to low and middle income countries. So I just wonder what your thoughts are on what any additional elements there might be when you think about sort of applying health opportunity cost to that sort of setting. And then sort of part B, my research is looking at alcohol pricing in South Africa, which is a population level fiscal policy. So it's a completely different prospect. So how would you even begin to think about health opportunity cost related to that sort of policy?
Okay, so the first one, for low middle income countries more broadly, I think I mentioned at the end of the presentation that our analysis here was completely reliant on this very comprehensive, complex study of using a lot of data from England. Now, that is obviously not going to be possible for many low middle income countries. There have been a couple of studies, I think one by Jessica Archalik, that looked at cross-country comparisons in expenditure and health outcomes, and she produced and her team produced estimates for a wide range of low and middle income countries. So that's total health opportunity costs, and so she's got health opportunity cost ratios for a whole range, I think more than 50 at least, low and middle income countries. So that's a good resource, good starting point. In terms of distribution, I mean, that is a very difficult task given the data restraints. I mentioned things like benefit incidence analysis, which was favored by the World Bank and has been, you can use survey data, so things like the demographic and health surveys, for instance, you can use that to look at health opportunity, healthcare utilization and healthcare expenditures. So that's one avenue by which you might be able to have some kind of information that you could then inform some kind of health opportunity cost distribution. Because I think ultimately, we need to do quite comprehensive scenario analysis whenever we look at these distribution, because it can have such a big effect on the overall inequality impact. So having some kind of informed baseline scenario would be, yeah, really, really helpful indeed. Regards to your other question, so that I think is obviously very complicated because it has all sorts of different implications in terms of the kind. So I guess the mechanisms would be through increases in taxation, per individual level taxation, and how those individual levels of how that affects consumption, how that affects their health. So you're talking about a much more complicated chain of effect. How you would model that empirically, I wouldn't even begin to think about, because it's very complicated. But I think in terms of just incorporating a distribution of health opportunity costs into your analysis, I think I would just go back to what I mentioned about having some kind of informed scenario analysis that could form the basis of your evaluation.
Thanks, that's really, really interesting. Could you send me that paper after at some point, and then I'll circulate that in the notes, the one that you mentioned. Thank you. I think if it's okay, we've got one more question. At previous IHEAR seminar, some of the attendees remained after the meeting to talk about what was happening during the pandemic. Do you think that? Okay. I'm not sure that's possible for this. Hi, Florence. I'm not sure that's possible for this webinar. I know I need to go to another meeting. I don't know what our IHEAR hosts might be able to keep this running for if there are people that want to do that. I'm not actually hosting the Zoom chat. So that's not a question for you, James. That's simple. But I would just like to say a couple of thank yous since we're coming up to our hour. So thanks, James, for presenting to us, and thanks, Stefan, for being our discussant. It's great to have everybody attend and for all the questions. We have got a session at the IHEAR Congress this year looking at equity informative economic evaluation in sub-Saharan Africa. So it'd be great to see some of you at that. That's it from me. I don't know if Alex, you wanted to say anything else?
Yeah, I just wanted to quickly remind everyone, as you'd said, actually, let me just share my screen. One moment. So we do have the upcoming Congress for July. So our early bird registration will close this Friday, April 30th. So I've posted a link just in the chat if you have a second, if you haven't registered already. We'd love to have you join us. So this Friday, April 30th, that special early bird pricing will close.
Great.
And aside from that, everyone, thank you very much for coming, and have a great day.
Thanks, Alex. Thank you. Bye.